Good afternoon. This is a special episode of Cuddles online neonatology series today. So today's session is going to be graced by none other than two pillars for this online series. We have our chairman and managing director, Dr. Bhaskar Rao sir, renowned cardiothoracic surgeon, and the pillar behind KIMS Hospital Group. We also have Dr. Sudhir, who is regional medical director of KIMS. I first hand over to both of them for their few words and what they have felt during this program's evolution. Over to you, sir.
Good afternoon, everybody. KIMS Cuddles Kondapur Neonatology Department proudly celebrates a significant milestone in its journey of knowledge sharing and clinical excellence with the successful completion of 100 weekly webinars under its online neonatal education series. I congratulate the entire team, leader Aparna and its team members, successfully done this 100E. This initiative, launched with the vision of enhancing neonatal care through continuous medical education and recent updates, has grown into a trusted platform for practicing pediatricians, neonatologists, and postgraduates across the country. The series has featured expert talks from neonatologists, pediatricians, intensivists, and specialists from diverse specialties like pediatric neurology, genetics, cardiology, gastroenterology, nephrology, endocrinology, hematology, oncology, ophthalmology, allied branches like lactation management, physiotherapy, covering a wide range of topics from evidence-based neonatal practices to the latest advancements in neonatal intensive care. The webinars also featured bedside demonstration of many practical aspects in neonatology, like ventilatory modes, pulmonary graphics, bedside echo, neonatal procedures, and clinical examination. With an emphasis on a quality content, interactive learning, and accessible education, the webinars have attracted thousands of attendees, including doctors, nurses, and medical students. This achievement reflects the relentless efforts of the Neonatology Department of KIMS Cuddles Kondapur, led by Dr. Aparna and our dedicated team, Dr. Aravind Lochana and Dr. Vamsi Krishna and Dr. Pranita Reddy. Their vision, hard work, and commitment to sharing clinical knowledge have been the driving force behind the success of this program. The team of neonatologists express heartfelt gratitude to all the consultants for sharing their valuable knowledge. As KIMS Cuddles continues its mission of nurturing tomorrow's healthcare leaders, this milestone serves as both as a proud moment and a stepping stone towards even greater accomplishments in the future. The team plans to conduct many more webinars on diverse topics, including clinical case-based discussions, objective structured clinical examination, and practical examination, aiming to support both academic growth and real-world clinical readiness. One way of conducting this, there are many students who get benefit. Not only the students, the consultants who participated, they also enrich with a lot of knowledge. And the patient attenders also, whoever is joins with them, they can also get upgraded their knowledge so that smooth clinical care, not only by the doctors at home, the parents also will be able to continue. This is a very, very good initiative. With this, every one of us will get benefit, and I congratulate the entire team, and I ask Aparna, take it little more and more initiatives and recognitions and take it forward in an innovative way where it will become more easy for the entire people of patients, the patient's parents, because 30, 40 years back, pediatrics means just one pediatrician. Today, the branch itself is so big. The neonatologists, the pediatricians, the intensivists, and the anesthetists. Not only that, there is a subspecializations in each area to understand the baby's needs and quality care. So I again insist that she should continue more and more webinars like this, and it will able to give more and more knowledge for each and every person who participate in this event. Thank you very much. And encouraging by this, that Sudhir, who has been the visionary to help the team to move forward and help what they need. And I'm sure without the administration, they would not have been very, very successfully come to this stage. Thank you.
Thank you for the lovely introduction, sir. I think that sets a very nice tone for the achievement from the entire team, and also your support being very instrumental and crucial to how we have set this up. Just to give going backwards, I think 12th of May 2023 is when we started this session, closely nearly 2 years ago, just short of 2 years. And fantastic achievement from Dr. Aparna and team. I think to name the entire team is Dr. Vamshi Krishna, Dr. Aravinda, Dr. Panida, and our new addition, Dr. Sindura has joined us. Just to give you the vastness of what was achieved in this last 23 months, we've had 9,800 views from the playlist that was created, which could be viewed by consultants, clinicians, nurses, and all healthcare professionals at home, with ranging of 75,000 views. And the playlist itself was watched 1,200 times, 12,000 times, sorry, and with a combined total watch time of 7,500 hours. All this could not have been possible because it is mainly the content that was presented in all these live webinars. It gives the entire medical community and the neonatal fraternity as such to be able to view this in their own time at the leisure of their during a weekend or in the evenings when they are sitting with patients. Sometimes you can actually look through and browse through the topics. We've covered up almost 99 and we're going onwards with the topics that we covered, which are very relevant, very practical tips from the experts. This, as always, it's possible through the teamwork. And I would like to congratulate once again Dr. Aparna and team for putting this fantastic thing together. We have the YouTube channel under the name of Cuddles 1, and the Neonatal Educationally Rewarding Program is one of the pillars of it. Of course, my thanks goes to the branding team who have been able to facilitate, and the IT team who have also been very supportive in doing this. As always, a journey of 1,000 miles starts with a single step. We took baby steps then, and now we are flying. And I would wish that the team sees many more such great pinnacles they will achieve through this wisdom. And one of the ideas that was being given by Bhaskar sir just before this was to include the OSCE type sessions to be able to facilitate the budding graduates, both medical and postgraduates, to be able to use this forum for their OSCEs, their day-to-day examinations, as well as the clinical skills that they will present. Today, there is so much of knowledge available out there. But when we want to consolidate this into a single forum, I think Cuddles 1 and the Neonatal the education series are the best, I would say, in all these. So with that, I think I congratulate the team once again. Well done, Dr. Aparna. Over to you and the team if you can hear us now. Hello?
Yeah. So thank you so much, CMD sir and Dr. Sudhir sir. So as sir beautifully began in his introductory speech, academics has always been one of the key fundamental requirements for a successful clinical program. And we at the Department of Neonatology of KIMS Cuddles, this is from the Kondapur branch, we sincerely believe that strengthening and structuring this academic initiative in the form of a weekly, consistent, structured program would enhance the quality of care and the skills required for delivering this kind of care for the smallest of babies across the state, and perhaps if the reach is really significant, even in other states across the country. So this was a small idea. When we started off, we wondered whether we would even continue this past the first few maybe weeks or months. But thanks to all the support from the hospital, Dr. Sudhir and his team, Dr. Rohini and her operations team, the branding team from Mr. Amit and Akhila, IT team, thanks to all of them, despite having some technical challenges in the first few weeks, we have been able to pull off and complete now close to 2 years or 100 weeks. A few months back, when I happened to go to Maharashtra for a program, I was pleasantly surprised when PGs there walked up to me and said, "Ma'am, we have seen you on your online webinars, and we have also seen Dr. Arvinda and Dr. Pranita and Dr. Vamshi." And these and similar incidents that happened in the last few months made me actually realize that this was really kind of creating, if not a very big, at least a small yet significant impact. So we are happy today that the program has completed 100 weeks and has kind of been widely viewed and appreciated. We also are open to constructive criticism and feedback on suggestions to improve it and take it forward to keep it more relevant to postgraduates and to pediatricians who cater to the large number of newborns today in our country. India has the largest number of newborn babies delivering across the world, and hence the responsibility of taking care of all these babies may not be possible only in a few centers located in the metro cities. It is a huge responsibility among pediatricians, healthcare providers, and nurses across the country in order to reduce mortality and morbidity amongst these babies. This would not have been possible without enthusiastic team of consultants. So when we began, we thought we will do system-wise webinars and try to have maybe 30 to 40 minutes of lectures followed by 15 to 20 minutes of practical demonstration. We began with ventilation and then other topics in respiratory management of newborns. Then we took up cardiovascular morbidities, hemodynamic instability. And then more and more work and contribution started actively pouring in from the team of NICU, Dr. Arvinda, Dr. Vamshi Krishna, Dr. Pranita, and now we have Dr. Sindhura. We also had Dr. Srujana, who are actively contributing to these talks. As we branched out into other areas like gastroenterology, hepatology, and neurology, the other pediatric enthusiastic specialists, super specialists who are part of our panel, have also contributed actively to the lectures. Our pediatric neurologists, our pediatric cardiologists, pediatric surgeons, our pediatric intensivists, pediatric nephrology, endocrinology, all the subspecialists on board, including our neonatal therapist and lactation consultant, have all been part of the lectures, contributing their little bit to the vast ocean of knowledge that was being created. And all these lectures being well received and appreciated by the postgraduates and students who are receiving the videos. So I think this 100th session would be incomplete without the inputs of our team here, without whose support this would not have been possible. So I'll now request Dr. Arvinda and Pranita, who have joined us today, to share their experiences with Cuddles 1.
Good afternoon, everyone. First of all, I would like to express my heartfelt thanks to Chairman and Managing Director, Dr. Bhaskar Rao sir, Regional Medical Director, Sudhir sir, and our Neonatology Head of the Department, Dr. Aparna ma'am, for providing me their constant support and motivation for being a part of this online neonatal medical education. It has been an enriching and rewarding experience for me as a teacher, first of all, to navigate through the online platform where we will be seeing the students virtually only, and then constantly looking for topics that keep them engaged, and delivering the lectures with the help of our support staff the operations and the marketing as well as the IT team. It has been a good experience, and we would like to constantly look for new topics that help to keep our students and our audience, mainly practicing pediatricians or postgraduate students, engaged. And we would like to come up with new topics every week and continue this online session in the same manner. Thank you, Ananda.
Good afternoon, everyone. Thank you, Bhaskar sir. Thank you, Sudhir sir. And thank you, Aparna ma'am, for this opportunity. I'm so glad that our Cuddles 1 lecture has reached this milestone. And we would like to contribute much more interesting topics in the future. And I hope these sessions are going to be a happy and learning experience for all of us. Happy learning. Thank you. I think Dr. Vamshi and Dr. Sindura are just attending delivery of a sick baby who delivered in the unit.
Work comes first. No.
So I think once again,
wonderful achievement, madam. Congratulations once again on behalf of all of us. We would love to see you reach greater heights through this channel and continue with all the contributions. I think kudos to the team. We would not have been able to do this without their support, and thanks to all of them. Yeah.
So thank you so much, sir. Thank you, Bhaskar sir, for joining us today. And for those of you who are viewing the video, we are planning to come up with webinars in a slightly different model moving forward. We'll be incorporating a few case presentations for an acute ventilated case, a preterm ventilated baby, term ventilated baby with asphyxia or meconium aspiration syndrome. We also wish to include growing preterm case as well as developmental follow-up case focusing on developmental disabilities, cerebral palsy, and neurological examination in the coming weeks. So please stay logged in. I think Dr. Vamshi is here. I'll request him to speak a few words before we begin today's use case.
I'm very happy and very honored to be part of this series of the Cuddles 1, where we are able to transfer our knowledge and be engaged with so many pediatricians and the neonatals for the world. I thank Bhaskar sir, Dr. Abhinay, Dr. Sudhir sir, and Dr. Aparna ma'am for giving this opportunity part of this team.
Sir, shall we begin with the session for the day?
Yes, madam, you can continue. Yeah, we'll sign out. Yeah, thank you.
So I hope the video is visible. The slides. So we'll be discussing OSCEs today. And we have chosen some 20 OSCEs from different areas, including a few X-rays, few statistics related questions, and we also have few point of care ultrasound related questions. Those of you who are logged in real time can actually kind of type in your answers on the chat box. So first question, are the slides moving? 2,800 gram male newborn delivered by normal vaginal delivery. The baby developed severe respiratory distress and cyanosis at birth and was resuscitated with initial steps followed by bag and mask ventilation. The baby had persistent cyanosis and bradycardia and required intubation in the delivery room and was referred to a tertiary care center at 2 hours of life. On arrival in the NICU, you note that the baby has bradycardia with heart rate of 50 per minute, is cyanosed with asymmetrical chest movement, and the breath sounds appear to be distant on the left side. They are significantly decreased on the left side. This is the chest X-ray. So this is, does anyone want to type in what is the condition? So I'm not sure how many of you are able to type in the answers. Yeah, I can see one answer, CDH, Dr. Priyanka. Yes, perfect. So this is a left-sided congenital diaphragmatic hernia. Sometimes we must remember that we may not be able to see this picture in the very first X-ray because it takes few hours for air to navigate through the baby's GA tract. you may sometimes only see a uniform or inhomogeneous opacity over one side of the lung. And subsequently, this might appear to be a gas-filled bubble loop on the repeat X-rays. Also, on careful clinical examination, it may sometimes be possible to appreciate bubble sounds in the hemithorax. So this is a classical case of congenital diaphragmatic hernia. Of course, commonest type, 85% of the time, is the Bogdalex hernia, which involves the left side. Rarely, much rarer, is the right-sided type of diaphragmatic hernia, which is called Morgagnian hernia. Now, diagnosis is CDH. What is the possible reason if this baby has sudden deterioration, and how will we manage? So a baby with a left-sided diaphragmatic hernia on ventilator, suddenly having bradycardia, cyanosis, what could be the reasons? We all know that in any ventilated baby, the possible reasons could be DOPE. DOPE is D for displacement, O for tube obstruction, P for pneumothorax, and E for equipment failure. Babies with diaphragmatic hernia tend to have pulmonary hyperplasia, mostly ipsilateral, but sometimes even contralateral lung, and they are at high risk for developing air leak. So in addition to tube displacement and obstruction, always have a high index of suspicion for air leak or pneumothorax, and facilities for draining of pneumothorax in the form of a butterfly needle or intercostal drain tube should be easily available when the baby is being managed for congenital diaphragmatic hernia. Now, if we do confirm that there is pneumothorax in the form of transillumination test positive or the chest X-ray showing evidence of pneumothorax, then the management would be in the form of placing an intercostal drain tube. Other commonly asked question is, what are the poor prognostic markers in diaphragmatic hernia? Now, there are some definite markers which indicate poor prognosis. These are early diagnosis. So antenatally diagnosed diaphragmatic hernia less than 25 weeks tends to have more severe pulmonary hyperplasia and is one of the poor prognostic markers. Now, other prognostic markers which indicate a poor outcome include liver in the chest, because these hernias generally tend to be larger and tend to be associated with more significant pulmonary hyperplasia. Babies with antenatal evidence of pulmonary hyperplasia in the form of observed to expected lung head ratio of below 45% or an absolute LHR, lung head ratio, less than 1. So two important markers that one needs to remember in prognostication in CDH are LHR and LTR, lung head ratio and lung thoracic ratio. So whenever you see an observed to expected LHR below 45% or an absolute LHR less than 1, this also is indicative of severe pulmonary hyperplasia. The other indication where we think of a poor outcome is associated cardiac anomalies. Now, inevitably, babies with CDH tend to have some degree of left ventricular hypoplasia, but if there are other structural cardiac anomalies, like congenital critical heart disease associated, then the prognosis can be particularly bad. Next question is, what is the best ventilatory strategy to manage this baby? Diaphragmatic hernia, we already saw, has a high association with pulmonary hypoplasia, and postnatally, these babies are at high risk of developing PPHN, that is persistent pulmonary hypertension of newborn. So in terms of the best ventilatory strategy, one needs to remember that one could begin with conventional ventilation. One could begin with conventional ventilation, but the baby needs to be managed with as minimal PIP or peak inflation pressure as acceptable, wherein you are just able to get adequate chest rise. PEEP should be set to minimize lung injury. Accept pH of 7.25 or more, provided the PCO2 is not climbing up to more than 65 millimeters of mercury. In other words, accept moderate levels of hypercarbia, provided the pH is more than 7.25 and the baby is hemodynamically stable. So practice permissive hypercapnia. Also accept saturations which are above 85 or maybe between 85 to 90%, and do not necessarily target sats which are between 90 to 95%, which is what we normally do. This is because using high pressures and targeting normal carbon dioxide can lead to unnecessary barotrauma and volutrauma in these babies with pulmonary hypoplasia. It might be a good idea to think of early rescue high-frequency oscillation when the baby requires high pressures. Usually, we would take anything more than a PIP requirement of 20 or 22 as a indication to consider high-frequency oscillation, or in even at lesser settings if the baby has an established air leak. These days, the tendency is towards stability in the pulmonary pressures and opting for slightly delayed surgical repair after the pulmonary arterial hypertension stabilizes. So CDH is not necessarily an indication for an emergency thoracotomy and a reduction of the hernia. It is much more important to stabilize the baby's general condition and the pulmonary pressures before we proceed with surgery. Next OSCE. Now, I'm sure all of you can see that this is a baby with mongoloid facial features. It is a baby with Down syndrome, trisomy 21. Questions here are, what is the most common malformation seen in this baby? So we know that there are multiple anomalies. There are multiple anomalies seen in babies with Down syndrome, including cardiac or gastrointestinal anomalies. So the commonest abnormality, 30 to 50% of the time, is endocardial cushion defect. So this is a specific type of cardiac anomaly seen in babies with Down syndrome. Now, possible reasons for recurrent vomiting or delayed passage of stools. There are multiple reasons again. Some common reasons are for recurrent vomiting, particularly, we know that Down syndrome has an association with duodenal atresia. Other common GI anomalies include Hirschsprung disease, which can be a reason for delayed passage of stools. These babies are also at high risk of hypothyroidism, which is also responsible for delayed passage of stools. So if you see this kind of history, one should definitely consider ruling out Hirschsprung disease. Of course, thyroid screening is something that is to be definitely done at 48 hours of age. And if this is abnormal, this may have to be repeated again at around 2 to 4 weeks postnatal age. Characteristic facial phenotypic features. There are multiple phenotypic features in Down syndrome. Some characteristic facial features include the presence of epicanthic folds, mongoloid or upward slant of both the eyes, the presence of flat occiput and flat frontal bone, presence of small nose, hypertelorism or widened space between the two eyes, presence of open mouth or protruding tongue, and the presence of small posteriorly rotated ears and flat nasal bridge. So these are all some characteristic facial phenotypic abnormalities, but the single most important sign of Down syndrome in a newborn would often be hypotonia. So neonatal hypotonia is present in almost 90% of newborns who are eventually diagnosed to have Down syndrome. Most of the other phenotypic abnormalities may or may not be very evident in the neonatal age group. So mongoloid slant, epicanthic folds, flat occiput, flat frontal bone, small nose, hypertelorism, open mouth, protruding tongue, posteriorly rotated ears, and a flattened, depressed nasal bridge. Of course, other abnormalities like clinodactyly and sandal gap are some limb abnormalities seen with Down syndrome. Now, Down syndrome screening is one of the important areas that we all should know when we are catering to perinatal medicine. So what are the important markers in maternal? Triple screen. And these days, we also do quadruple screen. Triple screen is a maternal serum testing that is done between 16 to 18 weeks of pregnancy. It includes 3 important markers: maternal serum alpha-fetoprotein, HCG, and unconjugated estriol. So how do we remember the pattern of abnormalities in triple screen? Easy to remember. H or HCG is high and the other 2 markers are low. Serum AFP and unconjugated estriol is low. In quadruple screen, in addition to these 3 markers, we also have inhibin A, which is also elevated in pregnancies with trisomy 21. In trisomy 18, on the other hand, all the 3 markers in triple screen are going to be low. So these days, almost in every pregnancy, we do see that triple screen or a quadruple screen is done. Now, if you want to go do the screening earlier in the first trimester, we do dual markers, which includes beta HCG and PAPPA, which is pregnancy-associated placental protein A. You see an X-ray on the left side where we see characteristic double bubble pattern. So there is a double bubble pattern of the gas shadow within the abdomen, and there is paucity of gas distally. Now this, when seen in a baby with Down syndrome, is pretty characteristic of duodenal atresia. There are multiple types of duodenal atresia. Sometimes we may see isolated duodenal web, but when you see double bubble sign, it's pretty characteristic of duodenal atresia. There are other causes of double bubble sign generally like annular pancreas, but when you correlate with the clinical presence of features of Down syndrome, you can almost always be sure that you're dealing with duodenal atresia. Okay, the next question is on point of care echo. So the question here is, what are we trying to see in this particular view? So you can see that this is a Doppler image of flow across probably some valve, and you can see that there is a calculation depicted on the top left of this square. It refers to the tricuspid regurgitation velocity. So this figure represents Doppler of velocity across the tricuspid valve. So this is one of the common measurements that is used for calculating the severity of pulmonary hypertension. So TR maximum velocity is measured on the Doppler image, which is usually from the apical 4-chamber view. You see all the 4 chambers of the heart, including the right side and the left side. We keep the Doppler gate across the tricuspid valve and try to measure the velocity. Now, how does this help us? The peak velocity is used for calculating the pressure gradient across the tricuspid valve using the Bernoulli's equation, where pressure gradient is equal to 4V square. 4 into peak velocity across the TR jet square. So if, for example, the velocity in the TR jet is 2 meters per second, so V square would be 2 into 2, which is 4. 4 into 4 is 16. So the pressure gradient across the TR, the tricuspid valve, is 16. Assuming that the right atrial pressure is usually equivalent to the CVP, which is normally or conventionally taken as 5, the right ventricular systolic pressure, RVSP, will be 4V square plus 5, which is equivalent to 21. 16 plus 5, which is 21. So this can be used to calculate the severity of pulmonary hypertension. RVSP is usually equivalent to pulmonary artery systolic pressure in regular circumstances. Now, the baby is on conventional ventilation with the following parameters: PIP of 25, PEEP of 6, MAP of 14. So here we are referring to a ventilated baby. Inspired oxygen concentration of 90%. Pre-ductal saturation is 75%. This baby is obviously having hypoxia, and the post-ductal arterial blood gas is showing pH of 7.27, PCO2 of 57, and PO2 of 30. Now, this is often asked in the exams, and this is also something that we do in real life. How do we calculate the oxygenation index? Oxygenation index, or OI, is one of the common metrics that we use to calculate the severity of hypoxemic respiratory failure. This is calculated by the product of MAP and FiO2. So mean airway pressure into FiO2 divided by the PaO2. So in this example, they have already told us that MAP they are using on ventilator is 14 centimeters of water, and the FiO2 they are using is 90%. So 14 into 90 in the numerator. In simple terms, you can remember whatever you are providing to improve oxygenation figures in the numerator. You give MAP as well as FiO2. It is to be divided by the PaO2 in the, what you get from the baby is the PaO2. So you divide by PaO2, the denominator. In this case, they had given it as 30. So 14 into 90 divided by 30 gives you 42. How do we interpret this OI? Anything which is more than 20 is indicative of hypoxemic respiratory failure, and OI of more than 40 on high frequency oscillation is indicative of severe hypoxemic respiratory failure. So this is often considered as an indication for ECMO. Next question. Name at least 2 maternal antenatal medications that can lead to this condition: NSAIDs and SSRIs, or selective serotonin reuptake inhibitors. The endothelin antagonist that is used for treating this condition, that is PPHN, is bosentan. So there are a number of drugs that are used for treating PPHN. The selective pulmonary vasodilator, which is often used, is inhaled nitric oxide. And this works by stimulating the levels of soluble cyclic guanylyl cyclase and increases the levels of cGMP within the smooth muscles and leads to pulmonary vasodilatation. Likewise, you have milrinone, which is a phosphodiesterase 3 inhibitor. We also have sildenafil, which is a phosphodiesterase 6 inhibitor, which also works by increasing the levels of cyclic AMP within the system. So all these cause smooth muscle dilatation. And there are other drugs, newer drugs, that are being used now for treating PPHN, and notably one of them is bosentan. Bosentan is an endothelin antagonist that is used to treat PPHN. Endothelin is one of the most important pulmonary vasoconstrictors. So the drug that is indicated when OI exceeds 20 is inhaled nitric oxide. Other question you can be asked here is, which OI must this be? Traditionally, we use the postductal OI for taking decision on the treatment of PPHN. Next is a clinical question. So you can see this video. This is a 28 weeks, 960 grams, who is delivered by preterm vaginal delivery. You can see that the baby is having significant retractions over the xiphoid, the upper chest as well as the lower chest. Upper chest usually refers to the area of the chest above the axillary line, the mid-axillary line. It is not the area of the chest above the nipple line. The baby also seems to have nasal flaring. Okay, so this is a baby with severe respiratory distress. Some questions. What are the prenatal interventions that would improve the outcome of this newborn? So, neonatology can never be complete without discussion of important prenatal interventions. And two very important interventions would include antenatal steroids and antenatal magnesium sulfate in a baby like this. Steroids, there are two different medications that we use. Betamethasone, which is given as 2 doses of 12 milligrams 24 hours apart. And dexamethasone is the other antenatal steroid, 6 milligram 4 doses. This is given 12 hours apart. Antenatal steroid course is considered to be complete if there is 24 hours that is lapsed from the last dose. There are other important prenatal interventions like appropriate management of PROM, and we must all be aware of the role of oral erythromycin that is coming up in the management of mothers who have developed preterm, pre-labor rupture of membrane. Some labor room interventions that improve the outcome of the baby. Now, when it comes to labor room interventions, our role as pediatricians or neonatologists becomes crucial. So some important labor room interventions are establishment of early or delivery room CPAP, delayed cord clamping, or other measures to improve the placento-fetal circulation. Delayed cord clamping is the only measure at least recommended below 29 weeks. We can use cord milking alternatively for babies born more than or equal to 29 weeks. Then comes the important steps in the thermal bundle, wherein we try to maintain the baby's temperature during admission to NICU. A combination of interventions, including the maintenance of labor room temperature, use of heated humidified gases for resuscitation, receiving the baby in pre-warm linen, receiving the baby in an exothermic mattress, and placing the baby in a polythene wrap before drying the baby. So these are all components of the thermal intervention bundle. Then use of appropriate blender for titrating the FiO2 concentration, targeting saturations right from the first minute after delivery, and recording the admission temperature, use of a T-piece resuscitator to provide gentle and sustained pressures during positive pressure ventilation, use of a blender to start with a FiO2 of between 21 to 30% while providing PPV are some of the important labor room interventions that will improve the outcomes of this baby. So the next question is a clinical question related to this particular video. So what is the distress score of the baby? Now, there are two important distress scores in newborn. We have the Silverman-Anderson score as well as the Downey score. So in this premature baby, we would prefer to use the Silverman-Anderson score. It has 5 components: upper chest retractions, lower chest retractions, Ziphy retractions, grunt, and nasal flaring. Now, if we look at the video, the baby has significant Ziphy retractions as well as upper and lower chest retractions. So Ziphy, maybe you would give a score of 2. Each of these parameters is scored 0, 1, and 2. Retractions are scored fairly subjectively. So 2 for Ziphy retractions, maybe 1 each for upper chest and lower chest retractions. Upper chest retractions are scored as 0 for no inspiratory lag, 1 for presence of inspiratory lag, wherein chest lags behind the abdomen when the baby inspiration, when the baby inhales, and 2 for seesaw breathing or completely paradoxical sort of breathing. So this baby does have inspiratory lag and would get a score of 1. 1 for lower chest retractions. There is presence of there was presence of audible grunting. We are not able to hear the video now of this clip, but this baby had audible grunting. That would again get a score of 2. Grunting heard with a stethoscope would get a score of 1, and there is nasal flaring. So 2 plus 1 plus 1 plus 2, 6 plus 1 for the presence of nasal flaring. So this baby would get a score of at least 7 by 10. Now, next question, what are the ultrasound chest findings in the baby? So in a baby with, let's say, RDS, very likely this baby has respiratory distress syndrome. The ultrasound findings that you would expect would be the presence of diffuse B lines, absence of A lines. Now, A lines are present in a baby with normal lungs, and they are generally parallel to the baby's, to the probe. And these are generally seen in a normal lung. When you have a lung that is consolidated or has evidence of respiratory distress syndrome, we would see B lines. And when you see confluent B lines, these are definitely abnormal. The other ultrasound chest findings that are abnormal include the presence of subpleural consolidation and diffuse alveolar interstitial syndrome, etc. On the other hand, the presence of the double lung point is one of the characteristic findings of transient tachypnea of newborn. Okay, what are the interventions that you would consider now that you know that this is a 28-weeker with high risk of RDS and their doses? So the two important interventions are CPAP and surfactant. CPAP is provision of PEEP in a spontaneously breathing baby to open up the alveoli, and the usual pressure that we start is 5 to 6 centimeters of water with FiO2 of around 40 to 50%. Of course, the more recent guidelines would mandate that you start with much lower FiO2s, barely adequate for targeting the pre-ductal saturations between 91 to 95%. You don't have to necessarily start with 50% and start with a flow of 5 liters per minute. Next question, what chart is this? Now, this chart, as you can see, has postnatal age in hours on the x-axis and serum bilirubin values on the y-axis. There are 3 different lines that correspond to the 40th, 75th, and 90th centile of bilirubin, and dividing this chart into 4 different zones: low risk zone, low intermediate risk zone, high intermediate risk zone, and high risk zone. This is Bhutanese pre-discharge bilirubin nomogram. And this is a nomogram that is used for plotting the baby's pre-discharge bilirubin against the, this nomogram to understand the risk zone of assessment before discharge. And this in turn helps us to predict the risk of subsequent severe hyperbilirubinemia. So you have low risk zone where the risk of severe hyperbilirubinemia is very small, is 0%. Then you have low intermediate where it's around 2%. Then we have 13% in high intermediate and close to 40% in the high risk zone. So based on these risk zones of bilirubin before discharge, and you can use either TSB or TCB, serum bilirubin or transcutaneous bilirubin for prediction of this risk, the baby can be appropriately called back for a follow-up visit. For example, a baby who is already in the high risk zone at discharge ideally should not be discharged, should be kind of monitored in the hospital itself for the next 12 to 24 hours for the development of severe hyperbilirubinemia requiring intervention, whereas a baby in high intermediate risk zone may be called back after 4 to 24 hours. So this chart extends from 0 to 144 hours of postnatal age. And there are some situations where one would prefer to do a TSB over TCB. TCB is, as you all know, a handheld cutaneous bilirubin machine that is being used for the pre-discharge risk assessment, also for ascertaining the rough value of bilirubin when the baby is clinically icteric. But there are some situations where the TCB is not really recommended. This includes babies with a TCB value which is more than 13 milligrams per deciliter, some would say 15 milligrams per deciliter, or if TCB is within 3 milligrams per deciliter within the phototherapy threshold. So if at a specific postnatal age, the phototherapy threshold happens to be 14, if you find a TCB of between 11 to 14, then it is ideal that you also do a TSB. It is also not recommended for babies beyond 14 days of postnatal age, and it is also not to be done for babies who are already receiving phototherapy. Barring this and barring the first 24 hours of postnatal age as well, a TCB is a fairly useful tool which can significantly reduce sampling losses because of bilirubin assessment frequently. Now, it's also important to remember risk factors for severe significant hyperbilirubinemia. These are different from the risk factors for developing bilirubin encephalopathy or BIND. So the risk factors for developing severe significant hyperbilirubinemia include low gestational age, jaundice appearing within the first 24 hours, pre-discharge TCB, which is close to the phototherapy threshold, phototherapy before discharge, parent or sibling requiring phototherapy or exchange transfusion, family history or genetic ancestry of red blood cell disorders, exclusive breastfeeding in the current infant, and the presence of hematoma scalp hematomas, scapel hematomas, and significant bruising, macrosomic infant of a diabetic mother. So these are all some risk factors for severe significant hyperbilirubinemia. In contrast, factors like asphyxia, significant lethargy, temperature instability, hypoalbuminemia, presence of isoimmune hemolytic anemia, G6PD deficiency are all risk factors for developing bilirubin-induced neurological dysfunction. The next question, what is this graph? So this is a flow volume graph that we use on a ventilated baby. This is one of the important pulmonary graphics or loops. You can see that there is volume on the x-axis and flow on the y-axis. So this is flow versus volume graph. So this is the flow volume graph. That is the first question. What is the abnormality here? So in this particular graph, you see that you can see that the portion of the graph above this horizontal line is the inspiration, and below the x-axis is the expiration. So if the flow volume graph is not touching the baseline from the expiration, then this is indicative of leak. There is air leak. Whereas if the expiratory flow touches this part, that is doesn't touch the baseline on the y-axis, then that is usually indicative of air trapping. What are the advantages of volume guarantee ventilation? So volume guarantee ventilation is a hybrid mode of ventilation where you can titrate the PIP that is required for each breath based on the complaints of the baby's lung and based on the tidal volume of the previous breath. Some important advantages of volume ventilation are that it reduces death or the combined outcome of death or BPD, grade 3 to 4 IVH or PVL, pneumothorax, hypocapnia, and it can also reduce the number of days of ventilation. Some of the important steps to prevent the VAP bundle are humidification, ensuring appropriate humidification. Horizontal sleeping endotracheal tubes can be placed. Do not keep the endotracheal tubes vertically. Try to have a suction checklist wherein 2 persons should always be doing suction. Ensure head and elevation and avoidance of H2 blockers, which can alkalinize the pH of the stomach and predispose to infections. Also ensure appropriate hand hygiene and enteral feeding with mother's own milk. Now, what sensor is mandatory in order to measure the tidal volume? It is, of course, flow sensor. Without having a flow sensor, it's not possible to do volume targeted ventilation. The causes for sudden deterioration of a ventilated baby, of course, would be DOPE, and it stands for displacement, obstruction, pneumothorax, and equipment failure. Next question, you are dealing with a 12-year-old term male baby with a birth weight of 3,000 grams who is being treated with septic shock with IV antibiotics and inotropes. The baby now presents with persistent thrombocytopenia. Baby had an umbilical venous catheter for the initial 5 days, which was removed, and a peripherally inserted central catheter was inserted in the left lower limb on day 6, which the baby, through which the baby was receiving inotropes. But currently the baby is out of inotropes and is just receiving IV antibiotics for infection. And the Doppler of the limb shows thrombosis along the left femoral vein. So you're dealing with a term baby who is having persistent thrombocytopenia on day 12 of life. So the question is, what are all the causes for late onset thrombocytopenia? Now, thrombocytopenia, as the question clearly is referring to, can be either late onset, as in this case, or it can be early onset, that is within the first 72 hours of postnatal age. Early onset thrombocytopenia usually is secondary to asphyxia, or it might be secondary to maternal causes, immune thrombocytopenia, which can be either alloimmune or isoimmune. Isoimmune, often seen with the systemic lupus erythematosus or other autoimmune thrombocytopenias in the mother. Alloimmune thrombocytopenia is where the mother's platelet count is normal and baby's platelet count is low. And this usually happens with alloimmune thrombocytopenic purpura, AITP, neonatal AITP, which is known to be associated with dangerously low levels of platelet count and high risk of intracranial bleed. Now, when it comes to late onset thrombocytopenia, which is usually beyond the first 72 hours, the common reasons are sepsis, either bacterial or fungal, necrotizing enterocolitis, disseminated intravascular coagulation, viral infection secondary to HSV, CMV, and the presence of indwelling central lines and thrombosis secondary to these lines. They can also be drug-induced. Some drugs which are known to cause thrombocytopenia are chloramphenicol, penicillins, even milrinone, which is an inotrope, inborn errors of metabolism, as well as Fanconi anemia, which is a cause for bone marrow depression-related thrombocytopenia. The most common cause for neonatal thrombosis in newborns is the presence of indwelling central lines, and this baby did have an indwelling central catheter. What are the possible treatment options for neonatal thrombosis? One should evaluate for causes for thrombosis, such as presence of indwelling lines or other de novo causes of thrombosis, such as the presence of prothrombotic conditions. Usually, we begin evaluation with a basic PT and APTT, prothrombin time and activated partial thromboplastin time. And based on the clinical setting, we may also look for some other prothrombotic conditions like the activated protein C deficiency, etc. Unfractionated heparin followed by low molecular weight heparin is often used for therapy. We generally start with a loading dose of unfractionated heparin at 20 to 30 units per kg. And this is usually overlapped with low molecular weight heparin at 1.5 to 2 milligrams per kg. In very selective cases where there can be life-threatening or limb-threatening thrombosis, we may use tissue plasminogen activator or TPA. The next question is about what do you mean by scrub the hub to prevent CLABSI? Now, CLABSI bundle has numerous interventions, starting from interventions to ensure skin asepsis, interventions to permit the aseptic insertion of central lines, and for maintenance of hub care. And scrub the hub is one of the important interventions under hub care. This implies to a step where one scrubs the hub for the center of the central line for at least 15 seconds using either chlorhexidine-soaked gauze or alcohol to prevent CLABSI. Last 3 questions before we wind up the session today. What is this position? This is a dancer's hold position for breastfeeding, where the mother would support the baby or the breast with her thumb and the index finger. 2 conditions where this is often used would be babies with hypotonia, such as Down syndrome or preterm low birth weight babies, or simply a baby with an unexplained hypotonia. Now, the signs of adequate or good latch would be the following. So WHO has given us 4 steps of good positioning and 4 steps of good attachment. So 4 steps of good latch or attachment include the mouth being wide open, the mother's areola being completely covered by the baby's mouth, and none of the portion of the lower areola must be visible. Part of the upper areola might be visible. Chin of the baby must be touching the mother's breast, and the lips must be averted. Now, HMOs is an important buzzword that we keep hearing now. This is human milk oligosaccharides. This is the 3rd important component or solid component in breast milk. HMOs are antibacterial, antiviral, and anti-inflammatory molecules that provide short-chain fatty acids, provide immune modulation, have prebiotic effect, and modulate intestinal epithelial response. Some absolute contraindications for direct feeding are mother on chemotherapy and an infant with galactosemia. So in these 2 conditions, these are generally taken as absolute contraindications for breastfeeding. Most of the other infections like HIV are only relative contraindications, and these can be discussed on a one-to-one basis with the family. Next question on recent advances and trials. This is a trial on preventing prematurity, which is a drug that has been shown to reduce preterm births. So the answer is aspirin. There was a trial named after the drug itself, aspirin, which used aspirin at a dose of 81 milligrams, low dose aspirin initiated from 6 to 13 plus 6 weeks of pregnancy, which showed 11% relative risk reduction in the incidence of prematurity. Aspirin itself stands for aspirin supplementation for pregnancy indicated risk reduction in nulliparous trial. The other interventions to reduce preterm births would be progesterone. So this was the aspirin trial that was published in Lancet 2020. It demonstrated a 25% reduction in early preterm births and 14% reduction in perinatal mortality. Last question on the classification of BPD, and we'll discuss the rest of the OSCEs in the next week. So you have a preterm 25 weeks, 750 grams neonate, now 36 weeks post-conceptional age, and this baby is on CPAP 5 centimeters and 21% oxygen. So what is the staging of BPD as per NICHD classification? Now, staging of BPD has evolved a lot. We started off with the early 2001 NIH classification, wherein a baby requiring oxygen persistently for more than 28 days was further classified as mild, moderate, and severe at 36 weeks post-conceptional age. If the baby didn't require any oxygen at all, it was taken as mild. Oxygen support up to 30% as moderate, and more than 30% or need for CPAP or NAPPB was taken as severe. Now, with the advent of more and more babies with BPDs being managed with non-invasive ventilation, the NICHD 2018 has come up with a slightly revised grading of BPD. So if a baby who is born premature, less than 32 weeks of gestation age, has clinical as well as radiological evidence of parenchymal lung disease suggestive of BPD and is still at 36 weeks of postmenstrual age, requiring oxygen for more than 3 consecutive days to maintain SATs between 90 to 95%, this may be graded as grade 2 or 3 BPD. If the baby is straight away on ventilator, invasive ventilation, there is no grade 1 BPD possible in that baby. Any baby requiring room air would be taken as grade 2, and babies requiring higher FiO2 concentration would be classified as grade 3. A baby who is on non-invasive ventilation or nasal CPAP or on high flow or nasal cannula then would be further graded as 1, 2, 3 based on the FiO2 classification. 21% grade 1, 22 to 29 as grade 2, and more than 30% grade 3. So this baby who's on nasal CPAP at 21% oxygen would fall under grade 1 BPD. On the other hand, if a baby is on nasal low flow oxygen or hood oxygen, FiO2 concentrations required up to 30% would classify as grade 1, and anything more than 30% as grade 2. Whereas if the baby was on less than 1 liter flow of nasal cannula, then there is no grade 3 BPD here. It's 22 to up to 70% is taken as grade 1 and more than 70% is grade 2. More importantly, a baby who is dying between the postnatal age of 14 until 36 weeks of PCA with owing to persistent parenchymal lung disease and not attributable to any other neonatal morbidity such as NEC and IVH is taken as grade 3A. So some allied questions. The ventilatory strategy that is most effective for reduction of BPD is NAPPB. The medication which when started immediately after birth is likely to reduce BPD is hydrocortisone. Surfactant strategy that results in the maximum reduction in BPD would be either less invasive surfactant administration or mist. Low dose DEXA is used for BPD if the risk is more than 65% after the first week of life. The most common regimen used for the treatment of BPD is DART, and this includes dexamethasone. So I think I'll stop here, and I thank you all for those of you who have joined us live today. You can kindly reach out to us on either on my number or on my email ID also to give any constructive feedback and suggestions for the upcoming programs. And thank you all for your ongoing interest in Cuddles online series. And we'll see you again next Friday with another session. Thank you so much.